Hi everybody, this is Dr. Chitra here, your mentor at Study Medic and Study EFOG. And we are back with our RRR series to help you in your preparation for your EBCOG Part 1 exam. Today we are going to be discussing questions from the module Maternal Medicine, and in that specifically topics like intrahepatic cholestasis of pregnancy and perinatal infections. So we would be discussing few SBAs and EMQs based on the type of questions that would be appearing in your exam, okay, and how you are going to come to choosing the correct answer. One thing before you keep in mind that winners are not people who never fail, but they are people who never quit. And this is only an exam that you're appearing. So I'm sure all of you have studied well. Go for this exam with a very clear and a calm mind, and you will clear this exam. And remember one thing, that even if you fail, never quit. Only this time wasn't yours. The next time you are sure to win. So let us first start with obstetric cholestasis. Now in this exam, what is going to happen is you are going to get scenarios that are very long and lengthy. The thing is that you have to read the scenario and mark the points which are really important. So as you read, you have to, some of the points which are not important, you have to just skip them out of your mind. Keep the ones that are important and then go to what is the most important thing that they have asked. Like, what is the recommended timing of birth over here? So, why are they asking what is the recommended timing of birth? Obviously, there is something wrong with her. So, let us see. So, you have this lady, the age really doesn't matter. What is her gravida, how parity, all that doesn't matter. What is that? She has presented with a 2 weeks history of generalized itching, worse at night. It involves her palms and soles, and there is no rash, abdominal pain, pale stools, or dark urine. So when you read this, immediately what should come to your mind is that yes, she's pregnant, there is itching without any rash. And previously, classically, they said that the rash was more at night and it involved the um, palms and soles. So the thing that should come to your mind, that this is obstetric cholestasis. Now, when you know that this is obstetric cholestasis and they are asking you what is the recommended timing of birth, you have to know the classification, that is mild, moderate, and severe. So for mild, you will deliver her at 40 weeks. For moderate, deliver her by 38 to 39 weeks. And only if it is severe, early birth is recommended at 35 to 36 weeks. So now here, what you have to see is you have to see what is her total bile acids, because that will give you an idea about what is her classification of IHCP. Okay, so go through the rest of the things quickly. Previous pregnancy uncomplicated, no liver disease, no gallstones, no diabetes, no preeclampsia. She's well, there is no rash. The fetus is well grown, fetal movements are normal. Now coming to investigations, yes, total bile acids is 39. So 39 means it is still mild, because 40 to 99 is moderate. Okay. And here liver function tests are also normal. Coagulation profile is normal. So now you know that it is still mild. So for mild, you can await spontaneous labor or you can deliver her by 40 weeks. So choose the option that is there. So here we do not have the option of deliver by term, but we have the option of await spontaneous labor. So that is the correct option here, deliver by 40 weeks, because like I told you, it is still mild intrahepatic cholestasis of pregnancy. The risk for stillbirth is similar to that of the background population. Okay. Now the next question is, you have this 29-year-old again. She has presented with intense nocturnal itching, which is affecting her palms and soles, no rash, ALT mildly elevated, total bile acids are 18. So now 18 means that this is not intrahepatic cholestasis of pregnancy, because mild that we saw, it is 19 to 39. So this is not intrahepatic cholestasis of pregnancy. Let us see what they are asking in the question. So she is anxious and requests immediate treatment and induction. She's asking for induction. What is the most appropriate next step in her management? So either you can say it is mild ICP and planned delivery at 40 weeks. No, because she is not ICP. Start ursodeoxycholic acid immediately. No, because we know that nowadays ursodeoxycholic acid is really not given in treatment for women, those who have IHCP. Repeat bile acids in 1 week. That could be one of the options because you want to see the trend of bile acids, whether they are increasing or decreasing. Planned delivery at 30 weeks, that also doesn't make any sense because you have still not come to a diagnosis. Arrange urgent CTG surveillance. Now, CTG also, we know that doing a CTG does not really predict or it does not prevent stillbirths in women, those who have intrahepatic cholestasis of pregnancy. So here the correct answer would be repeat bile acids in 1 week, because then you will know what is the trend of her bile acids, whether it is increasing or it is decreasing. If it is decreasing, that means she doesn't have intrahepatic cholestasis of pregnancy. If it remains at around 18, that means this is something that is called as gestational pruritus. Okay. Now, the third, again, a lengthy scenario. So you have this multi with worsening pruritus over the past 10 days. It is severe, constant, worse at night, again, affecting palms and soles. It is affecting her quality of sleep also. Then there is no liver disease, no other comorbidities. She is uncomfortable. Okay, there is no rash or excoriations. Blood pressure is normal, fundal height. That means fetal movements are good. Fetal growth is also good. Now, if you come to her total bile acids, it is 135. Okay. Again, ALT, AST is significantly elevated. That means her liver function tests are abnormal, but coagulation profile is normal. Ultrasound shows normal amniotic fluid, no structural abnormalities. CTG is reactive. So what they have asked you is the most appropriate plan of management for her. Now, if bile acids are 135, means it indicates that she has severe intrahepatic cholestasis of pregnancy. Now, for these women, the risk of stillbirth is very high. So it is advocated that they should deliver by 35 to 36 weeks. Okay. So the appropriate management plan for her, weekly CTG until 39 weeks, not really because it doesn't prevent a stillbirth. Start ursodeoxycholic acid and await spontaneous labor, definitely not because this is severe IHCP. Plan delivery at 35 to 36 weeks. I would not even bother to read what are the further options because I know that this is severe IHCP, and for these women, you will deliver her at 35 to 36 weeks. Okay. Now again, you have this lady who is seen in the antenatal clinic at 36 weeks gestation, already diagnosed with obstetric cholestasis. Now her investigations are bile acid 65, liver functions are mildly deranged. She has been managed conservatively. The fetal movements are normal. Mm, So now she is worried, okay, because she says that she is worried about the associated stillbirth. And she wants to know that if I come in for weekly CTG monitoring and scans, will this prevent my baby from dying in the womb? Now remember, her total bile acid is 65. That means she is not mild. She is in the moderate range. Okay. And we already know that if you do CTG even every day, it is not going to help us to prevent or predict a stillbirth. Okay. So, um, what is the most appropriate counseling that you will give her is that CTG and ultrasound do not prevent stillbirth. Okay. For this woman, you have to plan her delivery by 38 to 39 weeks because it is moderate. And even if you do a CTG every day, it will not prevent a stillbirth. Now, this 28-year-old woman at 35 weeks of gestation, again diagnosed with moderate obstetric cholestasis, she is presenting with itching or pruritus, and her investigations show that peak bile acid is 58. Okay. She was given ursodeoxycholic acid. Itching has improved. Fetal movements are normal. And ultrasound shows appropriate fetal growth and normal. Now, what she wants to know is, I am taking ursodeoxycholic acid every day. Does this reduce the risk of my baby dying before birth? What is the most accurate statement? So we know that ursodeoxycholic acid does not improve the outcome for the baby. It was previously thought that it will decrease the itching symptoms in the mother, but we know it does not have any effect on the perinatal outcome. So what you are going to tell her, it does not reduce adverse perinatal outcomes. Okay. It does not reduce stillbirth. It does not reduce perinatal deaths. Sometimes the woman can have a little bit of relief from itching. That is the only role that ursodeoxycholic acid plays in intrahepatic cholestasis of pregnancy. Now again, you have this woman in early pregnancy, 12 weeks of gestation. She has come with generalized pruritus. It is progressing over the past 10 days. It is worse at night, affects palms and soles. So that means it is all fitting into the description of intrahepatic cholestasis of pregnancy. What I am only worried about is the gestation, because it has started at 12 weeks or in the first trimester, which is something very abnormal because IHCP usually starts in the third trimester. Okay, let us see what they're saying further in this question. This is spontaneously conceived pregnancy, no past history of liver disease, no autoimmune disease, no viral hepatitis, no medications that she has been taken. She looks well. There is no rash or excoriations. Observations are normal. Abdominal examination is unremarkable. Total bile acids are 55. That means it is in the moderate range. And ALT, and that means the liver enzymes are also elevated. Bilirubin and coagulation profile is normal. Ultrasound shows it is a viable intrauterine pregnancy. Now, what is the next appropriate step in her management? That is what they are asking. So, diagnose typical ICP and routine management. I would not really go with this because ICP, I know it will not come on at 12 weeks. Planned delivery at 38 weeks, also no, because from now itself, you cannot say that she will remain in the moderate range. It might come down or it might even go up. It might become severe. If it becomes severe, then she delivers. She has to deliver by 35 to 36 weeks. Refer to hepatology for further evaluation. Start rifampicin or no further action. So rifampicin, we know it is not a drug that will be given in IHCP. No further action is also not correct because the woman is symptomatic and she is showing raised bile acids. The only option that we are left here is refer to hepatology for further evaluation. Now let us see why this is the correct answer, because like I told you, ICP usually presents in the third trimester. Now this woman, she is presenting in the first trimester. Okay, so that means that this is something atypical. Now whenever you have something atypical, you will always refer her to a specialist. Okay, so refer her to the hepatologist so that he can examine her, make sure that there is no underlying liver disease. Now you have this woman, she with obstetric cholestasis, labor was induced and she delivered a healthy baby at 37 weeks of gestation. During pregnancy, she has experienced all those itching and everything. After, like in the intrapartum, there were no complications. After delivery, her itching resolved completely. Okay, clinically, she is doing well. She wants to go home and she wants to know when further blood tests or follow-up would be indicated for her. So she says that now the itching has gone. Do I need any more checks or is this finished? So what is the recommended postnatal follow-up? Remember that even though now the woman is asymptomatic, okay, but you have to follow her up and to see that the bile acids come down to the normal level, and it will take some time for the bile acids to come down to the normal level. So you will not do them immediately she has delivered. It is recommended that you will do it at least 10 days after she has delivered. But usually for at 10 days, the woman, she will not come back for a follow-up. So it is at around 4 weeks that she comes back for the postnatal follow-up. So you will do LFTs and bile acids when she comes for the postpartum follow-up. That means more than or equal to 4 weeks in the postpartum period. If they have come down to normal and she is not symptomatic anymore, you know that this was definitely IHCP and she will not need any further investigations or any other management. But If after 4 weeks the bile acid hasn't come down to normal and also the liver functions are abnormal, then she will need further investigation. So you will refer her to the hepatologist. Now let us see a few EMQs. So in EMQs, what they will do is they give you a lot of options over here. And also they will give you a lead-in statement. They will say, they will ask you to choose the appropriate next step, okay, for the given scenario. So these are all the options here. And again, you have this woman, 30 years at 35, 30 plus 1, 31 plus 5 weeks of pregnancy. She's presenting with itching, no rash, bile acids are 18, fetal growth scan is normal, CTG is reactive. So what is the most appropriate step? She is not diagnosed to be still gestational. She is not still intrahepatic cholestasis of pregnancy. So what you can do is either you can go with the option of diagnose gestational pruritus, or you can reassure her and repeat bile acids in 1 week. Okay. So why reassure? Because you will not still diagnose gestational pruritus. Gestational pruritus, you will diagnose like if it is more than 19, then you know that it could be gestational pruritus. Like if it is more than 19, you will diagnose that it is intrahepatic cholestasis of pregnancy. But you want to make sure that the bile acids remain below 19. Okay, so you will repeat it after 1 week, and then after 1 week, if it is still in the same range, you can reassure her and tell her that this is a gestational pruritus. Now you have this 34-year-old at 35 weeks, 2 weeks of pruritus, bile acids are 39, LFTs are normal. So for her, what is the most appropriate management plan? 39 weeks means still she is mild. So you will deliver her at term, that is, deliver her at 40 weeks. You have this 37-year-old at 33 plus 4 weeks. Bile acids are 145, that means it is severe. No other comorbidities. The most appropriate management plan for her, you will deliver her by 35 to 36 weeks, because the risk of preterm increases significantly. Stillbirth increases significantly after 35 to 36 weeks. Again, here, they have not given a lead-in statement, but they are asking in each question, they have given you a question. Okay, so what you are going to do. So you have this 29-year-old with moderate ICP, and at 36 weeks, she asks about the baby's risk of stillbirth and whether weekly CTG will prevent it. So we know that weekly CTG is not able to prevent or predict a stillbirth. Okay, so don't believe that surveillance will prevent stillbirth. Then you have this 36-year-old with ICP, severe ICP, because the peak is 120. She is admitted in spontaneous labor. What is the most appropriate intrapartum management plan for her? So for here, you will advise to do continuous electronic fetal monitoring in labor. Why is it? Because we know it is not that because the CTG will prevent stillbirth, because women, those who have severe ICP, there is a very high risk of having meconium stained amniotic fluid. And meconium stained amniotic fluid, it could be indicating fetal distress. So that is why you want to know how well the fetus is adapting to this hypoxia. And that is why CTG or continuous electronic fetal monitoring should be offered to these women, those who have severe ICP and those who are undergoing induction of labor. Now you have this woman diagnosed with mild ICP. She delivers at 38 weeks. At 8 weeks postpartum, all her symptoms have resolved. She wants to know about the follow-up, recurrence risk, and contraception. She wants to also know about contraception. So they had asked to you two statements which are correct. Now, recurrence, you have to understand that any woman who has ICP once in this pregnancy, the risk of recurrence is very high. The exact risk they have not given in percentages, but remember that there is a very high recurrence risk in the next pregnancy. And for these women, in the next pregnancy itself, you will do serum bile acids and LFTs at the booking visit itself. Okay. And for these women also, for this woman also, even though all her symptoms have regressed, she still has to repeat her liver function tests. And the thing about contraception, that nowadays the new guidelines say that any woman who has ICP, no form of contraception is contraindicated for her. Once the LFTs come back to normal, any form of contraception can be given to her, unless previously she has a history of cholestasis with estrogen containing contraceptives. So in these women, like she has been taking estrogen containing contraceptives previously and she had cholestasis, then for these women, you will avoid estrogen containing and you can give all the other forms. So non-hormonal is the best, or you can even give only progesterone containing ones. This is the flow chart that is there for women, how to manage these women, pregnant women with itching. So basically, first you have to see whether the skin is normal or it is abnormal. Whenever a rash is present, you know it is not intrahepatic cholestasis of pregnancy. So you will consider other diagnosis and refer her to the other specialties. If the skin is normal, there is no rash, that is the time you will do bile acids and check the liver function tests. If bile acid is less than 19 micromoles, we know that this is not IHCP, it is gestational pruritus. Bile acids between 19 to 39, this is moderate. This is mild. 40 to 99 is moderate, and 100 and above is severe. Okay. And the management options we have already seen, and any woman who presents to you with ICP, whether it is mild, moderate, or severe, initially at least the bile acids and liver function tests have to be repeated every weekly to see what is the trend. And once they become stabilized, then there is no need to do them repeatedly. So this is the same thing again. They have given what is the management plan. So remember, for women, those who have mild ICP, you will consider planned birth by 40 weeks and no use of ursodeoxycholic acid for any one of them. The risk of stillbirth is the same as the background population for those who have mild ICP. Those who have moderate, you will consider for them a planned birth by 38 to 39 weeks. And those who have severe, for them, you will consider a planned birth by 35 to 36 weeks. So these are the important or the likely type of questions that you will get from obstetric cholestasis. Now coming to perinatal infections. So the important ones are rubella, parvovirus, HSV, and chickenpox. Let us see a few questions from all of them. Okay. So you have this community midwife because she has a pregnant woman at 20 weeks of pregnancy. This pregnant lady's son has developed chickenpox a day before. Okay. Now this woman is not sure whether she has had chickenpox herself. She is otherwise fit and well. So this woman, she wants to know, obviously she wants to prevent chickenpox being transmitted to her fetus. So she wants to know what is the best management option for her. The options are: ask her to come back if she develops any rash, check varicella zoster virus immunity, wait for the result, give immunoglobulin as soon as possible, reassure, do nothing as she's asymptomatic, or treat with oral acyclovir for 7 days. We do not want to wait till she develops a rash, because if she develops a rash, that means she has been infected and that infection will go on to a fetus. So what we want to know basically is whether she is immune or she is not immune. Whether, like, if she has, once we know that chickenpox, if you have chickenpox once in your childhood, the antibodies are going to stay with you for lifelong. So we want to know whether she has antibodies or she doesn't have. So the best option is check varicella zoster virus immunity and wait for the result. Okay. So usually if at the booking visit, if her blood has been preserved, the same sample can be used, and within 24 to 48 hours, you will know whether this woman has IgG antibodies. So if she has IgG antibodies, it means that previously she has already been exposed to the virus. She is immune, and now even if her son has developed chickenpox, she is not at a risk of developing chickenpox, and that's why her fetus is also safe. You have this woman with pelvic girdle pain. She's booked for induction of labor at 39 weeks. And at 38 plus 6 weeks, she has been diagnosed with primary varicella zoster virus. Now, remember, varicella zoster virus, the primary infection gives rise to chickenpox. Okay, so this woman has chickenpox, and the next day she is planned for an induction of labor. Now, remember that any woman who has chickenpox and is pregnant, it takes at least a minimum of 5 days for antibodies to form and for these antibodies to go to the fetus. If you deliver this woman in this acute phase of chickenpox that she has, the neonate is at a very high risk of developing neonatal varicella syndrome. So we want to prevent that. So any woman who has chickenpox 5 days or 5 days prior to her delivery or in the week following her delivery, the infant or the newborn is at a very high risk. Now, this woman, she has not delivered. What you can do for her, you will delay her induction by 1 week. Remember, for women, those who have chickenpox, vaginal delivery is not contraindicated. Cesarean section is indicated only for obstetric reasons. So for her, you will delay her induction for 1 week. Why? Because planned delivery should be delayed for at least 7 days to allow placental transfer of maternal antibodies. Okay, now you have this primary. She's a teacher, 16 weeks pregnant, and she has a student who has slapped cheek syndrome. So slapped cheek syndrome is caused by the virus parvovirus. Okay. So this woman, she is aware, she has never had this herself, and she's concerned about her pregnancy. So blood test is negative for IgG. That means previously she has not been exposed, and it is positive for maternal IgM antibodies. So IgM antibodies means what? That means she has had a recent infection, acute infection. An ultrasound which is done reveals a normal viable pregnancy. What advice would you give this woman regarding follow-up? Will you tell her that your ultrasound scan is normal now, so don't be worried, go home, the baby is going to be fine. Let us see what is the options. So she can be reassured and discharged if a second scan in 4 weeks' time is normal. She can be reassured and discharged in view of the normal scan. She should have 4 weekly growth scans from 28 weeks. She should have fortnightly scans until 30 weeks. If the scans are normal, she can be reassured and discharged. She should have fortnightly scans until delivery. Very confusing options. So, she should have fortnightly scans until 30 weeks. If the scans are normal at up to 30 weeks, she can be reassured and discharged. Okay. Now, why? Okay. Let us see. So you have this woman, already we know she has been infected with parvovirus because her IgM is positive. Okay. So you will do an ultrasound after 4 weeks of the illness or post estimated seroconversion. And if the affected, you will have any evidence of hydrops fetalis. If there is evidence of hydrops fetalis, you will immediately refer her to the fetal medicine specialist unit. But after 4 weeks, the ultrasound scan is normal. Okay, there is no evidence of hydrops. Then you will do repeat ultrasound every 2 weekly. Okay, so if the findings at any time are suggestive of hydrops fetalis, you will send her to the fetal medicine unit. But if 2 weekly scans also, they are normal, okay, then up to 30 weeks, like remember she has been infected at 16 weeks. So up to 30 weeks, you know that there is no abnormality in the scans. You can reassure her and tell her no need for doing repeated scans every 2 weekly. The fetus is not affected, and you can reassure her and she can be told to go for her normal scheduled antenatal follow-up. So it is said that you will repeat the scans for a period of at least 12 weeks after exposure. So here she was 16 weeks, 16 plus 12 is 28. So minimum of up till 30 weeks, you will see whether you are getting any evidence of hydrops or not. At 30 week scan, if there is no evidence of hydrops, you can reassure her that the baby is not affected and she can be discharged from follow-up. Now you have again this woman, third pregnancy. She comes for a routine prenatal visit at 18 weeks of gestation. Two kids are there. She's a school teacher. She has been exposed to a child with slapped cheek. Okay. She is asymptomatic. So, what is the appropriate advice that you will give her? She doesn't know whether she has had the disease previously or not. You will do amniocentesis for diagnosing parvovirus infection. You will do maternal antibodies, maternal middle cerebral artery Doppler measurements, reassure her that no further testing, or you will do umbilical cord sampling. Okay. For her, you don't know, or the patient also doesn't know whether she has been exposed or not. So to find out whether she is immune or not immune, you will do maternal antibodies for parvovirus B19. There is no need to go in and do amniocentesis or anything. First, you have to know whether the mother is infected or not infected. If the mother is infected, then further things have to be done. So, if she has IgG and IgM is negative, that means the woman is immune. She has been previously exposed to the parvovirus, and even if now she is exposed to someone who has the infection, that infection is not going to affect her fetus. Okay. And if both IgG and IgM are negative, that means the woman is not immune and she has not yet developed the infection. Okay. You see this lady who is 27 weeks into her second pregnancy and she has symptoms which are suggestive of chickenpox infection. What would be your further action? Already she's symptomatic for chickenpox. Admit to hospital, admit to VZIG, prescribe oral acyclovir, and advise immediate delivery or advise to deliver by cesarean section at onset of labor. Now here, because she already has chickenpox infection, so giving immunoglobulin is not going to be of any benefit. Immunoglobulin you will give to prevent development of chickenpox. She already has chickenpox, so what you can do, there is no need to admit to hospital because she doesn't look to have any other high risk signs and symptoms. No need for immediate delivery. She's 27 weeks and you will not deliver her by cesarean section. So you will give her oral acyclovir because it reduces the duration of fever and the symptoms of infection. Okay, we saw VZIG has no therapy, like no benefit once chickenpox has developed. Okay, and hospital and admission is necessary, like high risk factors. There is someone with immunosuppression, there are respiratory complications. For these women, you will advise admission. And in chickenpox, mode of delivery can be vaginal. It is not contraindicated. CS is done only for any obstetric indication. You have another multi at 39 weeks of gestation. Previously, she has delivered by a cesarean section and she has come to discuss the mode of birth in this pregnancy. Okay. This lady, she wants a vaginal delivery. So, what will you advise her regarding the mode of birth in this pregnancy? The catch here is that she is referred by the midwife who was looking after the lady, since the lady has active primary genital herpes infection. Remember, anyone who has primary active or anyone who has primary herpes infection in the third trimester, it is always advisable that they will deliver by a cesarean section because the risk of neonatal HSV is around 41% if they have a vaginal birth, and especially if the symptoms develop in the last 6 weeks of expected date of delivery. Now, this woman, she is at 39 weeks of gestation and she is having active primary genital herpes infection. So the newborn is at a very high risk of herpetic infection. So she will always deliver by a cesarean section. So this primary, 34 weeks of gestation, she has recurrent genital herpes simplex infection, and she wants to know your opinion regarding mode of delivery. What will you advise her? So remember, when it is recurrent, there is no contraindication to a vaginal birth, but what you can do for her, you can give her prophylactic acyclovir from 36 weeks of gestation to prevent any recurrence, or when any lesions are there, they will be suppressed. So those who have recurrent infections, for them, a vaginal birth is not contraindicated for herpes. She can have a cesarean section for any obstetric indications. Okay. Okay. Now let us see a few EMQs. So I want you to pause the slide, the video, read the options that are there, and then go to the questions on the next slide. So you will choose the correct option for the scenarios listed below. So you have this baby of a mother with primary genital herpes in third trimester, which is born vaginally. Okay. Mother treated with acyclovir in primary episode. Baby well at birth. So very high risk baby because the mother has primary herpetic lesions in the third trimester and she has a vaginal delivery. So for these infants, they are at a very high risk. So you will start acyclovir for them immediately. And at the same time, you will take swabs from various places, from skin, conjunctiva, rectum, and oropharynx. Okay. Until the swabs come back negative, till then you will continue to give the infant acyclovir. Now you have this primary with primary genital herpes at 12 weeks. What will you do for her? You will, because she has come at the first episode for you, you will refer her to the genitourinary physician. So remember, if she has come to you at the first episode, she will go to the gum clinic. And for this woman also, from 32 weeks, according to the new guidelines, you will give her prophylactic acyclovir. Now you have this baby of a mother with primary genital herpes in the third trimester treated with acyclovir. Mother has refused cesarean section and the baby is born vaginally, and at birth the baby looks unwell. Obviously, this is a primary infection and the baby is not looking well. So you will take the necessary swabs from everywhere, start acyclovir, and in addition, you will perform lumbar puncture to know whether there is infection in the central nervous system also. Okay. Then you have this 36-year-old recurrent herpes at 36 weeks treated with acyclovir, and she has a normal vaginal delivery. So if it is recurrent, then the infant is, or the newborn is not at a high risk. So you will give normal postnatal care. The risk of neonatal transmission in recurrent infection is only about 3%. Okay, and if the baby is asymptomatic at birth, no extra care is required for the baby. Another 26-year-old recurrent genital herpes treated with acyclovir from 36 weeks of pregnancy. Mother had genital lesions during labor and had a normal vaginal delivery. But remember, because it is recurrent, even though there are active genital lesions during labor, because it is recurrent, the risk to the baby is not very high. So you will keep the baby in hospital for a period of 24 hours, educate the parents about what they have to look on into the baby. So if the baby becomes very jittery, the baby is crying, the baby is not accepting feeds, then they will bring the baby back immediately to the hospital. Okay. Few more MQs about chickenpox. Okay. So this 26-year-old woman, she has primary varicella infection at 17 weeks of gestation. Now she's 22 weeks and she wants further investigation to determine fetal infection. She wants to know whether the fetus is affected or not. So what is to be done for women, those who have chickenpox? You will Not to do amniocentesis or an ultrasound immediately. You will wait for a period of at least 5 weeks after the infection in the mother. Okay. So you will do amniocentesis, but 5 weeks. So she has had the infection at 17 weeks. You will do amniocentesis after 21 weeks to see whether the fetal, whether the amniotic fluid has DNA of the chickenpox virus. Okay. Sorry. Now the next question is, you have this woman develops chickenpox rash 2 days after delivering a healthy term baby. Neonate is currently asymptomatic. Remember what I told you previously, that it takes around any child who is born within 7 days of the baby of the woman acquiring rash, that baby is at a very high risk. So 7 days prior to delivery or in the next 7 days after delivery, if the woman develops chickenpox rash, that means the baby is at a very high risk. For this baby, then you will administer VZIG because the baby is still immune. Okay. It has very high neonatal mortality. So you will give immunoglobulin to the baby. Then you have this 34-year-old woman. She develops varicella rash at 38 plus 4 weeks of gestation, goes into spontaneous labor within 24 hours of rash onset. Again, very high risk baby. So you can delay delivery for 5 to 7 days if possible. But it is not, you could be given tocolytics or anything, but why they have said is delay delivery, because it will allow transplacental transfer of maternal antibodies and reduce neonatal severity. A 30-year-old woman has confirmed primary varicella infection at 20 weeks of gestation. She delivers at term without complications, no documented immunity postnatally. That means she had varicella infection at 20 weeks of gestation. Baby is fine. And in the postnatal period, there is no documented immunity. That means this woman is still not immune to varicella. So in the postpartum period, you will give her varicella vaccination. Now, this vaccination, remember, you cannot give to the pregnant lady because it is a live vaccine, live attenuated vaccine. It can be given safe in breastfeeding, but after giving the vaccine, you have to tell the mother that she should be avoiding pregnancy for a period of 1 month at least. You have this 29-year-old pregnant woman who she has chickenpox and she develops secondary bacterial infections. Okay, skin lesions. So what will you do for her? You will give her prophylactic antibiotics because there is secondary bacterial infection. So you have to give her appropriate antibiotics. Now, this is the algorithm that is suggested for women, those who have chickenpox or those who have been exposed. Okay. So women, those who say that they have been exposed to someone who is a diagnosed case of chickenpox, you will determine whether this woman herself, if she gives you a strong history that yes, I have been vaccinated, or she knows for certain that she has had chickenpox previously, you can reassure her. But for women, those who say that I do not have the vaccine, or I do not know whether I previously have been infected with chickenpox or not. For them, you have to make sure whether she is immune or not. So you will check her booking sample to see whether she has IgG or not. Okay. So if IgG is present and the concentration is more than 100 international units per ml, you can reassure her and tell her that even though you have been exposed to someone who has had chickenpox, don't worry, you are immune and you are not going to get the infection. Okay. So women for whom this IgG is not present, what will you do for them? Because they are at a high risk of developing chickenpox. So nowadays, the first post-exposure prophylaxis that is given according to Green Top guidelines is you will give acyclovir, okay, 800 milligrams 4 times a day. Okay. Or if you are giving valacyclovir, you will give 1000 milligrams 3 times a day. If the woman cannot take this acyclovir, she has allergy or some contraindication, then the second line would be you would give her the immunoglobulin. Okay. Now, you have other women, those who come with chickenpox. Like they did not realize initially that she's exposed to someone with chickenpox and she comes to you with the rash and everything, or she is symptomatic. Then what will you do for her? For these women, you will give them acyclovir, because we saw that it reduces the duration of fever and the rash, it suppresses the rash. Okay. But acyclovir can only be given if she is more than 20 weeks pregnant. Okay. Now, if she has developed this chickenpox infection less than 28 weeks of pregnancy, there is a risk that the baby can have fetal varicella syndrome. The risk is very small, it is about 1%, but there is still a risk. So, any woman who develops chickenpox before 28 weeks of pregnancy, um, you will refer her to the fetal medicine specialist for a detailed scan 5 weeks after the time she had her infection. Okay. And there they will do a scan for her, and they might also consider doing an amniocentesis to see if the fetal mm, if the viral DNA is found in the amniotic fluid. So algorithm for HSV is, if there is primary herpes, onset is in the first and second trimester. That means up to 27 plus 6 weeks. Once it is 28 weeks, we know that it is the third trimester. So if it is in the first and second trimester, primary herpes, you will refer her to the gum clinic. You will do a viral PCR to confirm that this is herpes, and you will commence acyclovir for 5 days, and you will consider giving her from 36 weeks to prevent recurrent herpes. Now, intrapartum care, because it was in the first or second trimester, vaginal delivery can be offered to her unless some obstetric complication arises. And then neonatal risk, the risk of affecting fetus is low because the mother would already have had antibodies, and these antibodies will pass on to the baby. Now, if primary herpes is beyond 28 weeks, okay, so it is still primary. So when she comes to you in the first episode, remember you will refer her to the gum clinic. You will do PCR to see what is the type of virus. You will do IgG antibody assessment to know whether it is HSV1 or it is HSV2, and you can determine whether this is primary or secondary infection. Okay, so you will do the PCR from the lesions and you will do antibodies from the maternal serum. So you will know whether this is primary or secondary, and you will again start acyclovir and continue until delivery. So intrapartum care, you will advise her to deliver by cesarean section, especially if infection occurred within 6 weeks of delivery. Okay. If the woman, she declines, she doesn't want a cesarean section, you can consider giving her intravenous acyclovir in labor, and you will avoid doing any invasive procedures like fetal scalp sampling or fetal scalp electrodes. And the risk of affecting the baby is significant because a lot of time has not passed between the mother developing the infection and she doesn't have enough time for transplacental spread of antibodies to the baby. So the risk of transmission for the baby is about 41%, especially if she has a vaginal delivery. Now, if someone comes to you with secondary herpes, so you will liaise with the gum clinic, that is the genitourinary medicine clinic. You will do HSV IgG assessment as above. You will do a PCR from the lesions, and the tests will help you to confirm whether this is primary or secondary. You will consider starting acyclovir at 36 weeks of pregnancy, especially if those who have frequent flare-ups. Okay, but if it is HIV positive, you will start at 32 weeks acyclovir. Okay. So secondary herpes or recurrent herpes, vaginal delivery is not contraindicated. Okay. And the risk of the baby being affected also is very low in these cases. So these are the algorithms for chickenpox and HSV, and we have already discussed obstetric cholestasis. Thank you for watching the video. Hope it was helpful to you, and good luck to you for your exams. And do good. You'll be fine in the exam. Good luck once again. Bye bye and take care.